Good afternoon. My journal for today is about the profile of fluid exposure and recognition of fluid overload in critically ill children. This is by Al-Lawati et al. From Pediatric Critical Care Medicine of August 2020. As we all know, large amount of fluid administration is a normal occurrence in critically ill pediatric patients like shock during the initial resuscitative phase in pediatric ICU. Fluid overload is a common occurrence in PICU and is associated with increased morbidity and mortality. Many studies have shown that positive fluid balance is an independent predictor of first oxygenation, longer ventilation duration, and longer length of stay in pediatric ICU. The type and amount of fluid exposure, whether these fluids play a role in fluid overload, have not been studied in pediatric patients. Also, studies evaluating recognition of fluid overload by clinicians are also lacking. The study objective of this is this study aimed to describe the types and amount of fluid exposure in pediatric ICU patients on day one as the initial one and day three, and identify whether fluid overload is recognized by PICU practitioner. The study design is a descriptive analysis where cumulative fluid balance data and subset of fluid administered were measured as a continuous variable over the first 3 days of PICU admission. Daily fluid balance was calculated from the time they were admitted in increments of 24 hours from admission. Continuous variables were presented as median with interquartile range and mean with standard deviation. Categorical variables were presented as proportions. So for the fluid administration, the amount and type of fluid exposure on days 1 and 3 of PICU stay were examined. Why day 1 and 3? Day 1 to assess the initial fluid management when stabilizing the patient, as compared with day 3 where with fluid management later during the PICU stay when shock, if initially present, was already theorized to have resolved. And fluids were categorized into obligate fluids, so fluid boluses. These are fluid boluses, blood products, TPN, and enteral intake. While the modifiable fluids, these are the IV fluids and medications. For the fluid overload recognition, the assessment of patients admitted for at least 3 days for the development of fluid overload within 7 days from PICU admission. The fluid overload, this is the equation will be the intake, cumulative intake minus the cumulative output over the patient's weight during the PICU admission times 100. So they said that those patients having 15% of will be fluid overload. Um, they also examines clinicians' recognition of fluid overload with the documentation, like if there were anything in the chart regarding the patients having fluid overload, or was it mentioned in the chart or in the problem list. Also, the initiation of the physician for the minimum dilutional protocol. This is a pharmacy protocol wherein once the physician will initiate, then the pharmacy will maxim concentrate the medications to minimize fluid exposure. Also, the initiation of diuretic treatment. So the patients included in the studies are all patients admitted to the PICU for at least 24 hours over a month, and patients on extracorporeal renal or life supports were excluded. So 140 patients admitted during the study period. Out of these 140, 102 patients were included in the study, and these 102 were included in day one analysis. 38 were excluded because 37 of these were admitted less than 24 hours and one on peritoneal dialysis. And out of the 102 patients included in day one, only 54 were included in day three, since only these 54 were admitted for more than 24 hours. So what are the results? So for the total number of patients in day one, it was 102, while 54 in day three, with median age of 17 months in day one and 9 months in day three. 49 patients in day one were females, while 28 in day three. For diagnosis, more or less for day one and day three, they are the same with acute respiratory failure, status asthmaticus, bronchiolitis, pneumonia, septic shock, post-surgical management, malignant neoplasm or leukemia, and neurologic disease and end-stage liver disease, and others. For ventilated patients, there were 48 patients ventilated in day one, while 32 out of 54 in day three. Patients on vasoactive medications, so there were 13 patients on day one that was on vasoactive medications, while only 6 in day three. For the fluid boluses, 47 of the patients in day one had fluid boluses with median amount of 574 ml per body surface area or 20 ml per kg, while only one patient in day one received the fluid bolus. 16 patients in day one received blood products with a median amount of 256 ml per body surface area or 10 ml per kg, while only 2 patients received blood products in day 3. For the TPN, 12 patients received TPN in day 1 and 10 in day 3 with a median amount in day 1 of 1,317 ml per body surface area or 49 ml per kg, while in the day 3 it was 1,468 ml per body surface area or 57.9 ml per kg. For the enteral feeds, 22, the median amount of enteral feeds in day 1 was 22 ml per body surface area, or this is around 1 ml per kg, while in day 3 it was 724 ml or 28.8 ml per kg. Out of this, for the modifiable fluids, which are the IV fluids and medications, the median amount in day 1 was 1,646 ml, while in day 3 it was 750 ml per body surface area. The total amount of fluid received during day 1 was, the median amount was 2,318, while in day 3 it was 2,233 ml per body surface area. And the cumulative balance on day 1 was 812 ml per body surface area or 31.5 ml per kg, while in day 3 the cumulative balance was 414 ml per body surface area or 21.6 ml per kg. The median fluid overload on day 1 was 3.2%, while in day 3 it was 12%, with patients having more than 15% fluid overload, or 11 patients in day 1, while 19 patients in day 3. The urine output, the median amount was 2.6 ml per kg per hour in day 1, while 3.56 ml per kg per hour in day 3. Only one patient in day 1 had acute kidney injury who was oliguric based on the KDIGO criteria, while none had oliguria in day 3. So this is a graph of the showing the components of the fluid administered during day 1 and day 3. For day 1, the total fluids was 2,672, and out of this, the modifiable fluids was 1,747, and the essential fluids, or the obligate one, was 925. Of this, 406 were fluid boluses, while the enteral feeds was 262, 79 for blood products, and 156 for TPN. While in day 3, the total fluid was 2,223 with the essential fluids of 1,200. Of these, 912 was from the enteral fluids, 264 from the TPN, and 5 from the fluid boluses, and 8 from the blood products, and 1,023 for modifiable fluids, which are your medications and your IV fluids. For the fluid overload recognition, so 30 patients out of the 102, 69 patients admitted for PICU for the last 3 days, and 30% of this met the fluid overload criteria in the first 7 days of ICU admission. The patient developed fluid overload in a median of 2.5 days from PICU admission. And of the 30 patients, 7 patients had explicit documentation of fluid overload, meaning they had a documentation in their electronic record, plus they were on diuretics and or with minimum dilutional protocol. So 7 patients had explicit documentation, and 14 patients were recognized, seems to be recognized based on the surrogate markers with the use of the minimum dilutional protocol or the use of diuretics. So 14 patients had diuretics, and uh, 12 were on diuretics only, while 2 were on the minimum dilutional protocol plus diuretics. And so 21 patients out of the 30 patients were recognized as having fluid overload by clinicians, but around nine patients uh, where patients were already on the 15% fluid overload. They did not have any indications of fluid overload in their chart. So in this study demonstrated that resuscitative fluids contributed more on to day one of fluid exposure compared to day three, but they found that a large number of patients continued to receive significantly more fluids than maintenance requirement on day three of PICU stay. So this is an additional fluid exposure that was mostly due to partially modifiable fluid exposure, like your IV fluids and medications. So although associated with morbidity and mortality, the causes of fluid overload in ICU are not are unknown or not fully understood. So some postulated contributing factors to fluid overloads are renal injury, or with resultant oliguria and excessive fluid administration. And understanding the nature and the quantity of fluid exposure as a contributor to the fluid overload is important. And in this study, only one patient had acute kidney injury on day one and none on the PICU day three. But still, 43% of the patient met the 15% fluid overload during the first 7 days of their PICU stay. And also in this study, it showed that 87% of patients receive a total amount of more than the 1,600 ml per body surface area on PICU day three. This 1,600 ml per body surface area is the maintenance fluid. And this may point to the lack of awareness by the clinicians of the total amount of fluids that is being administered to the patient. So the maintenance IV fluid is defined as 1,500 to 1,600 ml per body surface area, or it is calculated using the weight-based method, and it is used to provide water needs and replenish physiologic losses. So the correct dose of IV fluid needed in critically ill patients is usually it's not fixed, like supposedly in intubated patients, or especially those on sedation and muscle paralysis. The maintenance fluid should not be the usual calculations that we are doing for the maintenance IV fluid. Should be revised, or it should be lower than the maintenance. Also, failure of recognition of fluid overload could lead to overprescription of IV fluids, like if the clinicians are not aware of the amount of fluid exposure created by medications, then sometimes we neglect to adjust our total fluid intake. So especially in our patients who are having large number of medications plus the infusions, additional IV fluids are usually unnecessary, as the total daily fluid exposure it usually exceeds the maintenance. So will the result help me in caring for my patients? Um, yes, because as what I mentioned, we should not only be aware of the type of fluids, but also the quantity and the amount that our fluids that our patients are getting. We should have we should modify our behavior also in prescribing IV fluids. Like we should have daily revisions or review of the total fluid intake that our patients are getting. And sometimes we don't need to give additional IV fluids as most of the time the infusions and medications, as what was mentioned, it sometimes exceeds the maintenance. So we can just request our pharmacy to dilute our medications in dextrose water rather than in normal saline. And in our institution, we are lucky to have with us our clinical pharmacist who can help us with this concentrating our medications and infusions, and also our clinical dietitians regarding the feed and or the TPN that our patients are getting. Thank you.